My name is Wendy Yee. I'm one of the home dialysis fellows in Toronto, Ontario, and I will be one of the co-chairs of the session.
And I have the pleasure of serving with Dr. Yee. I'm Claire Elias. I'm a nephrologist at the University of Alabama at Birmingham, and we welcome all of you here to this session today.
All right, without further ado, I'm going to introduce our first speaker. So Dr. Xavier Parada is an assistant professor of medicine and board-certified nephrologist at the University of Massachusetts School of Medicine and UMass Memorial Medical Center. He will be presenting his study today on the social determinants of health and kidney transplantation barriers amongst Hispanic patients.
Thank you, everyone, for the kind introduction, and thank you, everyone who is attending this session. On behalf of my author groups, I'd like to present small but very important work that we have been doing in our dialysis unit patients. As mentioned earlier, I'm assistant professor of medicine at the UMass General School of Medicine at UMass Memorial, a hospital that is just 45 minutes outside of Boston. I have no financial disclosures to inform. And I'd like to start with some learning objectives. So today, what I'm hoping to achieve is to provide an understanding on transplant perception among dialysis patients. At the same time, I intend to show the perceived barriers to transplantation that our patients have informed us. And I also hope to compare patients' perception on transplantation and then cross-reference those perceptions with what we have in the electronic medical record data. As a matter of introduction, I'd like to mention that minority patients with end-stage kidney disease have lower access to kidney transplantation. And this is true for all minorities, but specifically for Hispanic patients. Hispanic and Latino patients also experience longer wait times for kidney transplantation than non-Hispanic whites, even when diagnosed with end-stage kidney disease at a younger age and in better health. Social determinants of health play a pivotal role in accessibility for renal transplant in minority populations, and that's part of the reason why this work was inspired. As mentioned earlier, this is a small study that consisted on a survey that was conducted at an outpatient dialysis unit located in central Massachusetts. The questions were multiple choice, and it was centered around transplant eligibility and social determinants of health. This is not a validated instrument. Transplant listing status and barriers when then cross-referenced with information from the medical record. As a matter of results, we have that a total of 44 patients answered the survey. Of the patients that did not answer the survey, some of those were hospitalized for different reasons, or patients declined to answer the survey. The majority of folks were male, and 64%. And as mentioned earlier, please keep in mind that the responses of the survey are what the patient perceived as their transplant status. And then I'm going to show you how it corresponds with what we found in the medical record. Central Massachusetts serves a very diverse population, out of which becomes the majority of the patients that we treat. You can see here the breakdown of the different ethnicities, Hispanic being the minority that is most represented, but closely followed by African American and Asian. Patients reported that their income, in the vast majority of them, was less than $50,000 per year. And it should not come as a surprise that Medicare was listed as the most often insurance carrier that our patients would use. And you can see here the breakdown of the other insurance coverages. It is important to note that as education, the vast majority of our patients reported either 12th grade or less, or some college with no degree. And this is an important thing to know, because later on I'm going to bring this point back again. The minority of patients will report some degree, but again, the vast majority of folks will have a very low scholarly level. As noted earlier, with the ethnicity being the majority of patients, minorities, 27% reported that they would need a translator. And this is also important to know because our transplant letters actually are coming out in English. The languages that are, again, most represented, English being one of them. Patients can also select different categories in this survey, but Spanish was closely followed by English. And then we see other languages there as well. When I mention the scholarly levels of our patients, the point that I want to make here is that the letters that we sent to our patients with their transplant eligibility sometimes exceeded the 6 reading level that has been recommended by the MAA and NIH. So there might be some discrepancies there. With regards to the perceived transplant status, the vast majority of patients report yes when asked the question, do you want a kidney transplant? And also the vast majority of them, 78%, reported that they have completed their assessment. Transplant dialysis patients reported that transplantation education was done by the nephrologist, PCP, social worker, and nurse, meaning the healthcare team. In a minority of them, they were not, they reported that nobody had talked to them about transplantation. And the first educational session for transplant was often done after starting hemodialysis. Now, here are the results that are perhaps more interesting, which are the discrepancies. So when we ask our patients, are you actually listed active in the transplant list? Around 11 of them said that yes, they believe that they were listed. But when we cross-reference that information with the medical record, we found that only 5 were actually listed as active in the kidney transplantation list. So this was one of the main discrepancies that we noted in our cohort. Then when we ask our patients, why do you think you're not listed? Some of them reported comorbidities as being the main reason. But when you correlate that with what we found in the medical record, and in blue, you'll see that there are other reasons why the patient was not deemed eligible for transplant. Some of those reasons can potentially be overcome with proper information. For example, non-adherence to hemodialysis, or patients who might have declined evaluation, and even obesity. Those were listed in the medical record. However, the patients thought that other reasons were the ones that prevented them from having a kidney transplantation. So those are the 2 main discrepancies that we found in our cohort. So as key takeaways from this research and this work, we find that there are potential transplant barriers in our population. Whether these barriers pertains to language barriers alone or health literacy needs to be further studied. A portion of patients reported different transplant barriers than the ones listed on the medical record. And at the same time, they also reported that they will remain active with the transplant list when in fact they were not. All transplant letters were sent in English, regardless of the patient's listed native language. With that, we have come to terms that we need to do better, and we have further directions that we are focusing on. For example, extending the survey to other dialysis units to see whether or not the same pattern repeats. We are working concomitant with our interpreter services to find ways to translate these letters into the patient's native language. We are also thinking on using less medical jargon and using a system, for example, the stoplight, where we can show our patients whether they remain ineligible or further testing is needed versus active. And we're also reaching out to the dialysis unit companies in order to include the transplant listing status into the monthly report card in order to establish a more streamlined, concise information for both patient and providers. With that, I appreciate your attention, and I'm open for any questions.
Open the floor for questions. I can get us started. Thank you for that excellent presentation. I have a question in regards to the perceived versus documented reasons for patients not being eligible for transplant. What do you think is leading to the difference between perceived versus documented barriers?
Yeah, that's an important question. That's the key, I guess, finding from our study. I'm the only Spanish speaker physician in my practice, and when I talk to patients about their conditions, oftentimes they have seen other physicians. They may or may not speak the same language, and oftentimes I find information in the medical record about their healthcare, about their medications. But the patients sometimes said, nobody have told me that ever. Nobody has reported to me that I have 30% kidney function left, which I find surprising. And I believe there's still, we use interpreters in our interactions with patients, but I think a lot gets lost in that interaction. And whether or not is the use of the iPad for interpretation, whether is, the interaction between physician and patient that sometimes gets lost. That might be the cause of it. So we're still looking. I'm still not sure exactly what is the main reason, but I tend to find all discrepancies, not only the transplant listing status, but on a lot of other healthcare-related issues to them. I think the language barrier is an important one that needs to overcome, but still we're finding ways to improve that. Appreciate it.
Hi, Jared Post from Hartford, Connecticut, Hartford Healthcare. So we're just down the road there. So we also have a very large population that we serve that's Hispanic and Spanish only speaking. Have you used patient advocates? Because sometimes when we need that transition, we have patients who are Hispanic who do speak, and that finding someone who really can speak to that experience and then aligning the patient who needs with the patient who's already experienced it, just very positive. Thank you.
Appreciate it. Yeah, we're working also with our dialysis unit providers when we are doing the dialysis option education. Now we have the offering to do that in Spanish because, again, we have resources now that also speak Spanish. And obviously, there are not enough of these providers, right? There's a big gap, but I think we're making some strides in that regard. And again, community outreach and community support is key in this.
If I could just add real quick, we also started with our home therapies program, a monthly meeting that has patient care advocates in there who are some Spanish speaking who are able to support their peers. So that was just started a few months ago.
All right, thank you very much.
Thank you very much.
All right, so our next speaker is Dr. Michael Heung. He is a professor of medicine at the University of Michigan, where he serves as the Associate Chief for Clinical Affairs in the Division of Nephrology. His clinical and research interests focus on critical care nephrology, in particular, acute kidney injury outcomes and management. Today, we are looking forward to his presentation on an exploratory needs assessment for AKI patient education. Dr. Heung.
Thank you very much for the invitation to present our research here. This is partly my research, but I'm presenting on behalf of a host of collaborators, Drs. Daniel Murphy, Rachel Moken, and Patricia Cow, and also a larger work group from the ASN, AKI Now's Initiatives Education Work Group. So these are my disclosures. I have no relevant disclosures to this presentation. I thought I would start this presentation with hopefully what I think is a rhetorical question as to why we should be talking about AKI. Why do I care about AKI? Why should all of you care about AKI? Again, hopefully rhetorical, but just in case it hasn't gotten to some of you, I thought I would start with this. First of all, it's one of the most common complications among hospitalized patients. This is a large epidemiologic study that was done a number of years ago now that shows that basically 1 in 4 patients admitted to the hospital will have an AKI. That's 1 in 5 adults and 1 in 3 children admitted to the hospital. So the scope is enormous, and it's hugely consequential as well. So the same study basically looked at the pooled mortality, and basically the overall mortality is 23%. So again, nearly 1 in 4. And when you have very severe AKI, shown here on the right, dialysis requiring, the mortality is up to 50%. So it's a coin flip at that point if the patient's going to leave the hospital. So this is a very significant disease. A lot of what I'm going to talk about today is really what happens to those patients afterwards. And so I like to point out that discharge is victory. It is victory to get patients to survive the hospitalization, obviously, but that's not the end point. That really is just a new beginning. Because we know that AKI survivors face huge hurdles after their discharge. These include adverse kidney outcomes, such as a recurrent AKI. About 25% will have another AKI hospitalization within a year. Increased risk for CKD, end-stage kidney disease, cardiovascular events such as heart failure. Kind of goes on and on. I don't want to, just rail on and on, but these are all areas for opportunity. And complicating matters, or potentially one of the real key contributors to these adverse outcomes, is that studies have shown that patient awareness of AKI is poor. This is one study that I think really kind of highlighted that, and it is a basis for why we did the project I'm going to talk to you about. But basically, this was a study of survivors. They went through hospital charts. They identified patients that had a stage 2 or 3 AKI, moderate to severe. So at least a doubling of the serum creatinine, so pretty legitimate AKI. And then they surveyed all these patients, and they said, okay, how many of you knew that you had an AKI? And 80% of them answered no. How many did you have AKI? 80% answered no. So only 20% knew that they had it, right? That's kind of crazy, right? And this has kind of been shown in a number of different settings now. And you can say, well, maybe they didn't ask the right questions, so they did ask it different ways too. And so even if they said, like, did you have AKI? Did you have any problem with the kidneys? Okay, that captured a few more people, but it's still 53% that said, no, I didn't have an AKI, I didn't have any problem with my kidneys. So obviously, awareness is a big issue. If you're not aware, you're not going to take kidney protective measures with your health. And so that's kind of the long background to what we tried to do in our study. The aims here were to engage stakeholders in AKI care throughout the spectrum of AKI care to truly make sure we're getting a broad perspective of what was going on here. And obviously, one of the things we wanted to do was identify some of the barriers or perceived barriers to successful AKI education. And then, of course, to identify opportunities for future research or quality improvement in this area. So we conducted a focus group. We recruited stakeholders from each of these different stakeholder groups to do a virtual focus group event, and we had 32 people. Recognizing that 32 people in one discussion is really a lot, we broke this out to try to capture different domains of AKI education. So we had 4 breakout rooms in this virtual event. The first was focused kind of on the hospital to discharge time frame. The second looked at AKI education in the outpatient dialysis, so specifically those patients that needed dialysis, which is, of course, a very special and vulnerable population. Then we looked at long-term follow-up in the clinic, post-AKI education, and then also just slightly different AKI prevention, so patients at risk for AKI, what was going on for educating patients for that. We had transcripts of each of these rooms, and we de-identified them and then transcribed them, and then using an inductive approach we developed a shared code book of different things that we thought were relevant from this, and then we did some thematic analysis to arrive at some themes, and I'll share that all with you. This was the breakdown of our focus group participants. We had a lot of nephrologists. I guess nephrologists are the most enthusiastic around this, which I guess kind of makes sense. But we did have a number of patients or their patient advocates. We had pharmacists, nurses or APPs, other physicians representing primary care and hospitalists, and a couple of social workers as well. And I'm going to present the overall codes and themes that we described just to kind of set the stage. The codes we identified, I'm going to go over each of these in more detail with representative quotes and how we're taking this forward. But just to point out that we felt like these themes, these codes sort of map to two overarching themes, which is the patient healthcare worker relationship and then system-based factors, which again, all of us are probably quite familiar with. But so I'll go through each of these codes. The first was foundational knowledge, or really that lack thereof. The recognition we heard time and again from both patients, advocates, as well as providers, that there seems to be a low baseline or inherent knowledge of kidney function and disease in the general population, the general lay population. The quote, patients don't even know what the kidneys do. Dialing it back to the basics is important. And my personal experience, it definitely resonates with this. This quote, kidneys are hard, that's not an actual quote. That was my editorialization of this. But that's what I hear from medical students all the time. So I think that kind of flows with this as well, frankly. Communication, I think, is obviously key, and there were a couple of different aspects to this. First was perceived poor communication, both from provider to patient, but also between providers. And I think that was not something that we necessarily were thinking about ahead of time. So that was very eye-opening, in the importance of being on the same page when presenting information to patients. You can see the quotes here that went to that. And a lot of quotes were really helpful to identify what some of the barriers to effective communication were. These included things like severity of illness of the patients. Like oftentimes this is happening in the ICU. So patients talked about, sometimes patients are really too sick, too tired really to hear. And they have lots of competing problems, which again, any of us that have been in the ICU will, I think that's not hard to imagine. And so, these were some of the discussions we've had from this, some of the ideas that we would take from this type of code and theme is to make sure that we are having, again, coordinated communication between providers going forward. Setting expectations, again, I think this is pretty straightforward. A lot of patient perspective of mixed messaging, conflicting info, not sure what to look for. Also from the provider perspective, just the fact that, sometimes clinical medicine is hard, and none of us have a crystal ball, and so some of the inherent ambiguity. So I think this dichotomy between what the patient's perception is and how a provider might perceive this is another important take-home to recognize that. Not to make up answers, but just to acknowledge that. Protocols process, again, lack of standardized best practices for a lot of our care was one of the recurrent themes, and a lot of variability. And so one of the other things that we discussed after this in terms of these results is how can we better not necessarily protocolize all the care, but protocolize some of the education, have better resources in place to make sure this happens. And that, of course, feeds into the next code, which is time limitations. I think this one is pretty self-explanatory. The quote of, "This is such a pressurized environment." This is a quote from one of the primary care providers. 10-minute appointments. You have so much going on. How can you possibly provide all the information you need to these patients that are at high risk? And then this one always kills me, right? Things were always prioritized above the kidneys, right? So that's why we all have to be the kidney warriors and get out there and, And then the last code that we identified was this transitions of care concept. Again, I think pretty self-explanatory, but just hearing some of these quotes, especially recognizing, even providers, this is from a provider, recognizing that we can lose the patient, lose the patient to follow-up, but that's a very high risk. And so some of these I think were intuitive, but I think we learned a lot from these different codes and areas to work upon. So just in summary, several codes emerged from this, and we kind of grouped them into two overarching themes: the patient-provider relationship and the systems-based factor. There's huge gaps, unfortunately, here, but I like to think of that just as an opportunity for improvement, for us to do better. And the hope, as we kind of discussed, is that some of these themes in the codes can be used as a basis for direction to improve our care for inpatient AKI education. So again, I just wanted to acknowledge the work group members from the ASN AKI Now Education Work Group who are listed here. And if we have time, I'd be happy to answer any questions.
Maybe one question from the audience?
Thank you. This is great. Extremely important topic. I'm a nephrologist with Loma Linda University. And I believe the one component I often face is like educating our peers in other specialties about the incidence of AKI and how sick these patients are, how frequently they just come back, and just trying to absorb them into our outpatient practice and a quicker follow-up is such a challenge. And I think we need like that multidisciplinary approach, something like a renal rehab or something, if like the cardiac people do, would be awesome. Just wanted some idea how you feel about that.
Absolutely. Thank you for that comment. And although a lot of our focus has been on patient education, I completely agree that peer-to-peer education is critical. And I'm sure we all have stories, but you know, one that stands out in my mind is talking to urology colleagues. They have a patient with advanced CKD who has this tumor that's slow growing that they want to take out, but they're going to put him into most likely end-stage kidney disease. And so I asked them, like, how likely are they to die of this tumor? Because, you know, the 5-year survival of somebody on dialysis is 40%, you know, and they have no idea. They have no idea that they just think it's no big deal. We'll just put them on dialysis by taking this out. So not exactly AKI, but I totally agree with you that we need to do that. Another study we did from this AKI work group that also relates to that, we did a very simple study. We looked at the general medicine meetings that JGIM and the ACP meetings, and we just scanned the last 5 years to see how much education they got on AKI. Guess how many sessions they have? I'll give you a clue, it's a very round number. Zero, literally, for something that happens in 1 in 4 patients for hospital medicine, right? So yes, completely agree. Thank you for that comment.
Thank you, Dr. Heung. Next, I'd like to invite Dr. Alvin Moss. Dr. Moss is a professor of medicine in the Division of Nephrology and Geriatrics and Palliative Care at West Virginia University School of Medicine. He led the writing of the first and second editions of the clinical practice guidelines in shared decision-making in the appropriate initiation of and withdrawal from dialysis. He is also a co-editor of the Oxford University Press book, Palliative Care in Nephrology, as well as the chair of the Coalition for Supportive Care of Kidney Patients. He serves on the editorial board of the Clinical Journal of American Society of Nephrology, as well as the Journal of Pain and Symptom Management, and is a co-PI on the EXPAND product to improve shared decision-making for older patients, including dialysis ethics and improving palliative care. He is here to present on his project, Clinician Training, to provide patient co-created kidney disease education, including all the options.
Thank you very much. I've really enjoyed both of the presentations that have preceded me, and I think you're going to see a common theme. The word communication was definitely in yours, and we're going to talk about it today. I want to just call your attention, let's see if this works, to the word expand there, because this work is funded by the Patient-Centered Outcomes Research Institute, and really the PCORI title for our project is Improving Shared Decision-Making and Access to Non-Dialytic Treatment for Patients with Kidney Disease. And we decided, you know, you need a fancy name for a study for people to remember it. So we called it EXPAND, which is expanding, let's see, we don't talk about the whole thing, expanding and promoting knowledge. Expanding and promoting alternative care and knowledge in decision-making, or really expanding choice in kidney disease care. So one of the co-principal investigators, Dale Lupu, serves on the clinical advisory board of Monogram Health. The rest of us report no financial conflicts of interest. The learning objectives are really to describe the process of co-creating with patients decision aids for kidney failure treatment options. Like our presenters, whether 80% are not aware that they had AKI or whether they didn't understand whether they won the transplant list or not, we want to make sure that we are designing things that patients understand. We want to discuss how we developed this curriculum, and then really the meat of our results are what did our clinicians tell us in terms of this curriculum that we developed? Was it successful or not? So what have we heard from patients? Much like our presenters before us, we had 4 patient focus groups. We have a national patient advisory group. Patients already feel like they're a failure. They just feel like, I have kidney failure. I've let down my family. I'm a failure. I didn't take care of my kidneys. They've been traumatized by the diagnosis and the treatment. You know, we think of cancer patients, when they're told they have cancer, they maybe don't hear anything else in the rest of the clinic visit. And our patients describe the same sort of thing. So they really appreciate a positive, empathetic delivery style. And they even told us, it's as important how you talk to us as what you talk to us about. And so that was very important. And they really prefer easy to understand information. They really wanted things at a health literacy level of like a grade 5 reading level, okay? And several of you commented on what's the health literacy of the materials we're giving them. And they wanted patients who were portrayed in the educational materials that looked like them. Close to 30% of dialysis patients are Black Americans, 15% are Hispanic, but a lot of the educational materials, all the patients are white. So they really wanted materials that looked like them. And then just to underscore patient decision aids, they're to help improve shared decision-making. What have they been shown to do? They standardize the information that's presented in a balanced way, including the benefits and risks. They can use videos and images. They can present information in an easy-to-understand health literacy level, enable patients to have more accurate information, empower them by really giving them this accurate information that they can use so they can be involved in the decisions, help them to make more informed decisions, and then have less decisional conflict. Did I make the right decision or not? Am I comfortable with the decision I made? So we took the advice of our patients, right? This is a novel idea, and we created 3 patient decision aids. We have a slide set, originally came from NKF, Council of Advanced Practice Providers, and then we created a less than a 3-minute video. And by the way, if you're interested in seeing the video, I will be showing it Saturday at 2:30 in the session on conservative kidney management. And then one of our people on our team suggested that why don't you make a patient handout at a 5th grade literacy level in a question and answer format on the front, and then a side-by-side comparison table of home dialysis, in-center dialysis, and active medical care without dialysis. And so that's what that is. Now, one of the things, as you're going to hear, because we gave this training to clinicians, and one of the things that I'll show is that they were not aware of the elements of shared decision-making and even how to do shared decision-making with patients. Patients have reported, as you know, they weren't aware they had a choice about dialysis or not, or even that there was a decision to be made. They didn't get a chance to express their values. They weren't informed of all their options, the benefits and risks of each, and the prognosis. They weren't given an adequate time for the decision. Often they were rushed, and they didn't feel like they were a co-equal in the decision or a co-equal in developing the plan. So the curriculum that we had was basically 3 training sessions. 2 of them were an hour and a half. It was about 5 hours total. We had 13 objectives. I don't have all 13 listed here, but for example, explain the 9 elements of shared decision-making and participate with patients in it for kidney failure treatment options. As you'll see, that was the one where they felt they had really gained the most in terms of objectives. Apply a cultural humility, trauma-informed care lens to patient-centered care. Describe changes of theory as it applies to shared decision-making. So we had a bunch of objectives, but I'm showing you the 5 where we saw the largest statistically significant differences. If you look at our participants, we had 76 in the training. 20% were advanced practice providers. 38% were nurses, 13% were nephrologists, 5% physician assistants, 4% social workers, and then we had administrators as well. But this is the meat of our results, okay? So the thing that they said they most increased their confidence is their confidence in knowing the 9 elements of shared decision-making, and their feeling that they would be capable in participating with patients in shared decision-making. You can see this was a highly significant p-value, but also a large effect size. So even though we had a small sample size, we had a large effect size. So, and this is just a spaghetti plot of what was their confidence level in participating in shared decision-making before and after the trainings. This over here is before and then afterwards. So you can see really a very nice increase in knowledge and confidence as a result of the training. So, just out of curiosity, a little audience interaction. How would you describe your practice's kidney failure treatment options materials in presenting active medical care without dialysis? How many of you don't present it at all? Raise your hand. Okay. All right. How many of you present it as no dialysis? You know, this is a wise group. How many of you present it as conservative care or conservative kidney management? Okay. Bunch of hands going up. How many present it as end-of-life care? All right, everybody knows the socially acceptable answer on this one. How many presented as active care with the description of what the care includes? Okay, less hands than conservative care, but a few hands went up. All right, so that's basically the gist. Oh, you haven't started waving at me yet. That's the gist. Notice that we had patients, including even 2 of whom have already died since we first started this. A bunch of patients on the left. We had nephrology clinicians in practices all over the country, and we had producers of our video who are actively involved in medical education for patients. So what's the take home for this? After online training, I forgot to mention maybe this was online training, you know, by Zoom. We all know what Zoom is, right? After online training, nephrology clinicians reported a large increase in confidence in using the 9 elements of shared decision-making to participate in kidney failure treatment options decision-making with their patients. And since, Wendy, you introduced me as somebody who had helped lead the development of the clinical practice guideline on shared decision-making, we're now 25 years out, and all the research shows shared decision-making is still suboptimally implemented in the care of nephrology patients. So perhaps we've got a breakthrough with this approach. Thank you very much.
Yeah, the audience, we can maybe have one question.
Is this training available to everyone?
Is what available?
Is this training available?
Oh, so no, actually it's part of our PCORI grant, but I think, I know we recorded all the sessions. Thank you for that question. We recorded all the sessions, and I'm wondering if we could, if there's interest, we could make them available online so that people could watch them. And the video I'll show you on Saturday, and that we're going to make available.
That would be great. Thank you.
All right, thank
Thank
you.
you.
All right, so as we set up the presentation for our next speaker, is Anna Laura Licon, she is a program analyst in the Department of Internal Medicine, Division of Nephrology, and at Kidney Epidemiology and Cost Center at the University of Michigan. She received her biostats degree from the University of Michigan, and before working as an analyst, she worked as a scientist at a small startup company developing spider silk biomaterials. Later, she worked as a graduate student at the University of Michigan and was involved in a lot of kidney disease-related projects. Since graduating, she's continued as a full-time analyst for the team, and her research interests include health disparities, social determinants of health, and nutrition. So we are looking forward to your presentation.
Hi everyone, happy to be here. My presentations would be a little bit different than the previous talks today, but I think it's still interesting. So I'm going to talk to you about the population burden of cardiovascular kidney metabolic syndrome rising among US adults. This is the list of the people that have worked on this, and we have nothing to disclose. So for some learning objectives really quickly, we want to understand that CKM syndrome is a complex interaction between cardiovascular diseases, kidney diseases, diabetes, and obesity. And we want to recognize that the prevalence of CKM syndrome is increasing in the country, and we want to identify the correct characteristics that increase the likelihood of having CKM syndrome. And we also want to describe the increased risk of mortality in the more advanced stages of CKM. So in 2023, an AHA Presidential Advisory Board described CKM syndrome as a complex and adverse interplay of cardiovascular diseases, kidney disease, diabetes, and obesity. And it's divided into 5 different stages, ranging from stage 0 all the way through stage 4, with increasing severity. So we looked at data from NHANES between the years 2001 and 2020, and we looked at adults over 18 years old. We took the definitions, the 4 different stages of CKM, and we made them into 3 different groups. And I'll describe on the next slide how we defined each stage. But basically it was no CKM or stage 0, then early stage CKM, which would be stages 1 and 2, and late stage or stages 3 and 4. We looked at some time trends of CKM, and then we did some modeling. We looked at logistic regression, and we did some hazard ratio analysis to look at the mortality of CKM. So this is how we defined the 4 stages of CKM. We started basically with stage 4 and then expanded the groups moving up the stages. One thing we didn't have in NHANES was subclinical cardiovascular disease, so we used the Framingham risk equation to kind of calculate subclinical CVD. This is a time trend of the overall prevalence of CKM stages, and the circled orange line is stage 0, and we can see it clearly declining over time, which means an increase in all the other stages of CKM. This is a figure of just stage 0 or no CKM by the different race groups in NHANES. The biggest decline here is seen in the prevalence of stage 0 for Hispanic adults, but we see this decline in all the race groups. This is a figure showing the prevalence of all the CKM stages by different age groups. And what we see here is that those who are younger tend to be in earlier stages of CKM, and those who are older tend to be more towards the later stages of CKM. Next, looking at our logistic model, this is all the demographic associations that we had in the model. We can see that with increasing age, we see an increased likelihood in CKM, both in the early and late stage CKM. Being male is also at increased likelihood for having CKM, particularly late stage CKM. Compared to whites, those who are Black or Hispanic also had a higher likelihood of having CKM syndrome. And we can also see that that time trend was significant with that 4-year cohort. Next, looking at our socioeconomic associations with CKM, we can see that increasing income is protective of CKM compared to lower income. Having a college education is also protective of CKM compared to having just a high school education. And interestingly, insurance seems to be having insurance seems to be increasing your likelihood of having CKM. We think this may be due to some of the self-reported nature of the NHANES study. Then if we look at the health behaviors associated with CKM, physical activity is protective for early and late stage CKM, with increasing activity being more protective. Smoking in early stage CKM seems to be protective. This may be potentially due to the fact that those who are smokers tend to have lower body weight. So maybe we're including some people within that group that don't quite fit that CKM definition. We also looked at meals not eaten at home. That wasn't very significant. But we did also look at self-reported sleeping problems, and those who report having sleeping problems are at increased likelihood of having CKM. Finally, we looked at the adjusted mortality by the different CKM stages. We adjusted for age, sex, and race. With our reference being no CKM, we can see as the stages of CKM increase, we also see an increase of that hazard ratio of mortality. Stage 1 seems to have a lower mortality compared to those with no CKM. One hypothesis we have for that is that because stage 1 is mostly people who are obese, we may not be classifying that obesity correctly. Because we are using BMI, we may be including some people that are just very muscular and probably very healthy. For some strengths and limitations, strengths, we were using NHANES, which is publicly available data. It is weighted to be nationally representative, and we can track some time trends in the prevalence of CKM on a national level, which we haven't seen reported before. For some limitations, like I mentioned earlier, we did not have subclinical data available in NHANES, so we did use that Framingham risk equation. Some, but not all of the data that we got from NHANES comes from self-reported surveys, so there may be some bias there. And because we just did logistic regression, we can only establish associations and not causation. So for some quick conclusions, CKM syndrome has increased over the past 20 years with a significant decline in the proportion of people who don't have any CKM or risk factors. We see a rising prevalence in the stages 1 and 2 of CKM, which suggests an opportunity for both earlier detection and management of the risk factors such as obesity, and for screening components for CKM to prevent progression to more advanced stages, including more advanced stages of CKM, which include CKD and cardiovascular diseases. Any questions?
Okay, we may have time for one audience question. I had one quick question to ask. One of the curious findings that you presented, I guess at least to me, was the non-statistical significance of the meals not eaten at home. I don't know, that just seemed kind of interesting or surprising to me. Was any other information available about that, or was anything else from your results, I guess, sort of interesting or surprising to you?
I think it warrants further investigation. We do have more nutritional data available in NHANES that we can look at. Something that might be interesting to look at is looking at sodium intake. Mm-hmm. Or any of those micronutrients as well.
All right. Thank you very much.
Our last presenter for this session is Mollie Horn, who is the Vice President of Home with DaVita, covering the Midwest geography, and she will be presenting on increase in conversions from peritoneal dialysis to home hemodialysis, a pilot study of a structured education process.
Good afternoon. Thank you for having me. These have been some great presentations, and I agree there is definitely a theme as you hear about education, communication with our patients, decision-making. I think you'll find that this sort of falls into that same group of topics. So I'm going to start out by just acknowledging that there was a great group of people working on this pilot study, and so I have wonderful colleagues at DaVita. So Bernie Del Rosario partnered with me in creating the pilot, and then Miran Neljan and Eric Winehandel both have helped with the analysis and the research following. So for disclosures, all of the authors of this study are employees of DaVita. A little bit of background. So about 20,000 patients initiate peritoneal dialysis or PD every year in the United States. And it's interesting to note that within 5 years, nearly 50% of those patients transition to a hemodialysis modality. However, less than 2% of them actually choose to stay home, which is where they are currently dialyzing and choosing HHD as that modality of next choice. We believe that the transition to HHD is actually incredibly important for two primary reasons. One, a transition from PD to in-center hemo actually has an increased likelihood of hospitalization for these patients and an increase in mortality. So the study was really done around if we educate patients in a structured process and we do this upstream, can we impact these patients' choice of next modality and create a smooth transition? So it's important to note where we did the pilot study at. So I covered the area in orange. This represents about 3,000 PD patients and 500 HHD patients. This is a pretty large group of patients, and we did replicate this study or this pilot across this entire group. We started out by figuring out how we were going to identify our high-risk patients and staging them into 3 different groups. So the first stage is really about patients who are just PD patients. We know that lifetime therapy for PD is limited, and so we want to make sure that all patients are getting educated in some way from the day they start PD until they may need to make a transition. And so those patients are getting education during their initial PD training about modality choice. They are then getting refreshed education both at 6-month intervals every year. And then the next 2 stages are stage 2, which we classify as a moderate risk for loss to PD, and then stage 3. The criteria we used for this was adequacy, serum albumin, history of peritonitis, and history of hospitalization. So as those increase, their risk factor increases. All right. So I think the important thing to note on this one is, we utilized looking at patient records to do the analysis work following the pilot. And we defined PD conversion as anyone who had an HHD treatment within 60 days of their last PD treatment. And so we do have a little bit of a tail on there. So the results that we found from our study were actually quite interesting. The prevalence of young males converting was higher than that of any other groups. We had incredibly good outcomes. This graph here is showing this time period in basis of quarters. And so you can see the purple line is the pilot region that we did this study in. And we've seen a nice exponential climb as we began to educate these patients. And I'm very happy to report that we've continued to see this same climb yet in 2025. And so overall, we saw a 229% increase in our ability to successfully convert patients from PD to HHD through this process. And what we actually found was that 77% of these patients were actually converting within the first day from their PD to HHD treatment. And so they really weren't spending a lot of time stopping in center in between. And so you do still see some of that, but I think this process really helped to put people on a nice transition path. We didn't see like a huge discrepancy within hospitalization, although I will say it does show that when patients transition from PD to HHD, that we do see that reduction in hospitalization versus PD to in-center. We really thought we would see more anecdotal shift in vascular access placement versus CVCs, and we have not yet seen that. However, it is something that we're still really leaning into, and we think that if we can continue to do upstream education, we can also start to really add in the upstream access management to capitalize on this. All right, so the study was pretty successful. We were able to identify these high-risk patients. We were able to really implement a good structured approach for getting these patients educated and increasing their likelihood to transition from PD to HHD. And then furthermore, we really have not seen any exposure limitations to this. And then, like I said, we've not seen a drastic change in how we're doing vascular access, but we do still believe that there is opportunity there. As I think about things I learned throughout the study, and that as we start to think about scaling this sort of nationwide within our group, it is incredibly important that we have nurse and physician buy-in. In areas where we had really slow adoption, we had slow nurse buy-in, slow physician buy-in, and so really getting ahead of that, I think, is important. Process adherence is critical. Like, the education and the steps are there for a reason. And then you got to couple that with the outlier management. So if you have areas that really are just struggling to continue to get in there and really understand the patient's needs and then educate appropriately, you're going to run into some barriers. And then it's really important to make sure that you're getting upstream as much as possible. When I talk to our physician partners about this, I talk about it in terms of how you would think about programs like CKD education. Before a patient starts a dialysis, you want them to have several opportunities to be educated. You want them to have time to make a decision that's right for them. You want to have time to have access planning. And so it's really important that we not wait until they are crashing to their next modality before we start making these decisions. With that, I'll take any questions.
Great presentation. Congratulations on your wonderful outcomes. So I want to know what you told your patients that they were so willing to make this transition, and what is their satisfaction now with having done it?
Yeah, so what we actually did was we created an assessment tool. And so we started out by talking to patients about what was important to them about PD. And then we utilized that information to help them understand how HHD could offer something similar and just on a different modality. And then we would listen to the things that were barriers for them and why they thought maybe that wasn't a good option for them, and see if we could remove those barriers. Yeah, and then we've had a lot of patient satisfaction from it, and a lot of the patients who wound up in center and then converted later, went and tried in center, and really the things that they were missing was home. And so it's nice that we're being able to pull in that partnership with our in-center teams to continue that education and continue to pull in the home team where appropriate, so that we can help get those patients back to a place where they choose to dialyze.
This was very interesting, and I wonder if you have any thoughts on why there were more males willing to change than females?
I'm not sure. It was interesting when we did the data. In fact, Eric did the analysis for us, and we actually see a higher prevalence in our market there in that region with males doing HHD across the board. And so I don't know that I have an answer for you on it, but it is definitely a higher prevalence in that region.
I know you said that you wanted to avoid patients crashing into center hemodialysis. Was the decision to transition done sooner? Was there specific criteria, or is it physician-driven?
Yeah, it was physician-driven, and one of the things that we really, as we rolled it out, were trying to help people understand is that just because you have a patient that's showing as high risk and you're starting to do this education doesn't mean you stop trying to make them successful on PD. You can run those two paths parallel at the same time. So if your patient is flagging because they have a declining KT over V, for example, you don't stop trying to fix that. So you continue to work on that while you increase education. And and let the patient know that there is a chance that we're not going to be able to achieve the best dialysis for you. And at that point, we're going to need to talk about what your next decision looks like.
Thank you so much for that excellent presentation. I'd like to just have one more round of applause for all of our excellent presenters.